Yes, sir, we can start with the
Yeah.
session.
So today's topic is obstetric critical care. In the obstetric critical care, there are few area which is very important. One is your obviously preeclampsia, eclampsia, amniotic fluid embolism, postpartum hemorrhage, and the HELP syndrome. HELP syndrome you will get in the lab, in the CVS, or preeclampsia you can get in the CBS also, or you will get as a short case, either preeclampsia or postpartum hemorrhage. The obstetric critical care, one of the hot topic for EDIC exam. So every alternate year, they either give the case or they give in the lab value. So you have to know all about the HELP syndrome and preeclampsia. This two is the most common topic, and sometimes they can give of amniotic fluid embolism. So this is the case. This is about your 28-year-old primary gravida, 34-week gestation, present in ICU with headache, blurred vision, breathlessness for 6 hours, 190 by 115 mmHg is the blood pressure, heart rate is tachycardic, hypoxic, tachypneic, proteinuria present, bilateral infiltration, and lab value showing the low platelet, AKI creatinine is 1.9, AST, ALT, and LDH is higher, reflex is breaks, and urine output is low. So then the question was, what is your diagnosis and initial priority of management, and then the management of hypertension. The model answer saying that your diagnosis would be severe preeclampsia with pulmonary edema and multi-organ involvement. So if you give this answer, you will get full marks. Then obviously you have to give the differential diagnosis. But unless you complete severe preeclampsia, pulmonary edema, multi-organ involvement, renal, hepatic, and hematologic, they will not give you the full mark. So differential, peripartum cardiomyopathy, ARDS, pneumonia, that. So when we are talking about immediate priority, again, you have to approach airway breathing circulation. So airway breathing here, you have to tell about you will take care of the airway, you assess the airway. If the GCS is low, you will give airway protection, you will facilitate the maintenance of the oxygenation, because here the oxygen saturation is 86% on the air. So you have to take care of the oxygenation. Then your priority is the circulation. C is the control blood pressure reduction. And because it is a preeclampsia, so high chance of seizure, so seizure prophylaxis. And there is already there is a bilateral your chest X-ray showing bilateral alveolar infiltrate. So there is a pulmonary edema. So you have to talk about the fluid restriction and diuresis. And also because it's an obstetric case, so you have to utter the fetal assessment. These are your keyword. So you have to cover all these things. Then you can tell anything about your other management. Okay. Now, hypertensive emergency in pregnancy and in-organ dysfunction is the priority of management over here. Coming to your next, management of hypertension. So management of hypertension, when you will utter, don't jump on the drugs. So first, your target, gradual reduction. of the blood pressure. Targeted blood pressure will be systolic 140 to 150 and diastolic 90 or less. So avoid reduction more than 25% in the first hour. And first line of management, I will use the levotalol. If levotalol is not work, then we can add hydralazine or nicardipine. Avoid nitroprusside here. Just 1 minute. Hello. Sorry. So next is your seizure prophylaxis and control, fluid management, obstetric consideration, monitoring, supportive care, and complication. So seizure prophylaxis, yes, everybody after the magnesium sulfate, you have to tell the doses regimen also. So pictured per regimen, 4 milligram, uh, 4 gram IV over 5 minutes, then 10 gram IM, 5 gram each buttock. Then that is then 5 gram IM 6 hourly for 24-hour post delivery, and monitor your deep tendon reflex, respiratory rate, and the urine output. Treat toxicity 10 ml 10% calcium gluconate. If there is a magnesium sulfate toxicity, that time the examiner might ask, how will you understand that toxicity is happening? So features is it reduces the deep tendon reflex, the respiratory rate will be higher, and the urine output will be low, and patient may be agitated or drowsy. So fluid management of this patient, because there is a bilateral infiltration, strict fluid restricted, less than 80 ml, including the drug, input output chart, avoid fluid bolus here. Instead, fluid bolus, use furosemide because pulmonary edema is there, and consider non-invasive ventilation or intubation if refractory hypoxia, central venous pressure not routinely useful. You can do the echocardiography to evaluate the further fluid status in the lungs, B-line, IVC, whether collapsing is IVC collapsing or not, and the VTI is the more useful. Then you have to monitor supportive care, continuous ECG, invasive blood pressure, SpO2, urine output, serial labs, already you have mentioned, and fetal heart monitoring is very important. Avoid nephrotoxic drugs because already there is a creatinine high. Thromboprophylaxis once platelet more than lakh or bleeding risk minimal. Otherwise, thromboprophylaxis not recommended. Complication anticipated can have seizure, eclampsia, DIC, HELP syndrome, renal failure, pulmonary edema, ICH, abruption, and postpartum rebound hypertension, renal dysfunction, pulmonary edema. So complication and postpartum management, long-term care, if they ask, usually they not ask in the initial venient. So that's why I'm not asking these things. So then the scenario is more of a HELP syndrome, platelet drop from 80 to 45, AST, ALT, all increase, bilirubin increase, blood pressure, and the urine outflow. So here the question was diagnosis and pathophysiology and grading and prognostic significant immediate priority. So HELP syndrome is your diagnosis, severe variant of preeclampsia, microangiopathic hemolysis, and the LDH is high, and cystocyte is the diagnostic of microangiopathic hemolysis, elevated liver enzyme, low platelet, pathophysiology, endothelial dysfunction, microvascular platelet aggregation, hepatic sinusoidal obstruction, hemolysis, DIC, hepatic infarction or rupture that is happen in the HELLP syndrome. Now, grading and prognostic significance. This is your this chart you have to remember. The Trinis classification of syndrome. One is the class one. Hello. Class 1, class 2, and class 3. Class 1 is where platelet is less than 50, AST is more than 70, LDH more than 600. But class 2, 50 to 100, and class 3 is 100 to 150. And these are the thing. Higher class get a maternal morbidity, DIC, hepatic rupture, ERF, and ICH. So then you come to immediate priority of severe HELLP syndrome, stabilized maternal condition. Again, you have to utter the A, B, C, D, E approach. A is the protection of the airway, breathing, and then circulation. Here, circulation priority is management of the hypertension, and then seizure prophylaxis by continued magnesium sulfate for seizure prophylaxis. As is the complication, here high chance of DIC, hepatic rupture, or AKI. So DIC, your PT, APTT fibrinogen, or you can utter that you will do take to identify the problem. Because if you do the take, you will understand the factor problem, fibrinogen problem, APTT, PT. Hepatic rupture, ultrasound is good enough bedside. You can do CT, but ultrasound is enough. AKI, you will check urine output and creatinine clearance. Definitive management is the delivery. So as early as if possible, can do the delivery. So then you have a hematology and transfusion management component, blood product. So that will be your target, FFP, hemoglobin, and the platelet. Then hepatic complication and monitoring. Hepatic complications is there is a chances of rupture or necrosis of the necrosis. So you have to do serial LFT monitoring, liver function test, and also you have to do serial USG. And if there is a hepatic rupture, so resuscitation, packing, ligation, hepatic artery embolization, and transplant in refractory cases. Renal and multi-organ support need your fluid management, diuretics if volume overload, or early RRT and maintain MAP 65. Postpartum long-term care, if here they will ask, then continue magnesium sulfate 24-hour post-delivery, monitor lab until normalized, and counseling. Recurrence risk is 25% in subsequent pregnancy, screen for chronic hypertension and metabolic syndrome. If end here, or if not end here, they will not ask the question. So complication anticipation is again the same: DIC, liver hematoma, rupture, AKI, pulmonary edema, ARDS, ICH, stroke, and maternal mortality 1 to 3%. Then here the second scenario that from HELLP syndrome to seizure, tonic-clonic seizure. So it's a eclampsia. Now in eclampsia, again, they will ask about your immediate priority of management and the resuscitation. So immediate priority of management, again, you will utter the ABC. So it is whenever the new scenario arise or there is a question for initial priority of management, you have to start with ABC. If you have already intubated the patient, you will tell that my patient is intubated, so I'm taking care of the airway. Now I have to check the breathing and circulation. Breathing, our target is maintain SpO2 more than 94%, and this is and circulation is maintain the blood pressure, map more than 65, monitor ECG, prevent aspiration. It is their thing when it is patient is not intubated. That's why you have to prevent the aspiration, left lateral tilt, cough, etc. if intubated. Again, the seizure management, magnesium sulfate is the seizure management. Specific anticonvulsant here, the magnesium sulfate is the drug of choice, and recurring seizure. So repeat magnesium sulfate and monitor the toxicity by deep tendon reflex, respiratory rate, and urine output. Antidote, if there is a magnesium sulfate toxicity, then 10% calcium gluconate IV slowly is a antidote. And second line, already said the rare. Second line is the diazepam or midazolam, benzodiazepine. There is no role of your sodium valproate or phenytoin or levetiracetam in the guideline. So blood pressure control, goal to reduce blood pressure systolic 140 to 150, and the drug of choice here labetalol or nicardipine infusion. But always you utter avoid nitroprusside, which carries extra marks, and continue IVP monitoring, investigation, post-seizure, ABC, electrolyte, renal and liver function test, and also DIC screening, CT, MRI brain after stabilization if neurological deficit there to rule out ICH or Press syndrome. So delivery planning, definitive treatment of eclampsia, preeclampsia, HELP syndrome. The definitive treatment is delivery, and once the maternal stabilization, you can go. You can do the vaginal or cesarean section depending upon the patient clinical condition. Avoid regional anesthesia. If platelet less than 75, go for the general anesthesia. Involve multidisciplinary team, the obstetric, anesthetics, neonatologists, and intensivists. Supportive post-ictal care, maintain left lateral tilt because the gravid uterus compress the IVC. Fluid restriction, urine output monitoring, reflex and respiratory rate hourly. Continue magnesium sulfate always till after 24 hours of the delivery because there is a chance of postpartum eclampsia. Evaluate for aspiration pneumonia and pulmonary edema, chest X-ray, ABG. Complication anticipated. Again, recurrent seizure, ICH, Press syndrome, cerebral edema, aspiration pneumonia or pulmonary edema, DIC, renal failure. Postpartum long term, you have to gradually taper your antihypertensive, neurological follow-up if the neurological deficit is there, and counseling for future pregnancy risks and your cardiovascular monitoring. So then either they will end here or they can continue with PPH. If they give the delivery scenario, either they will enter in the PPH or they will enter in the postpartum cardiomyopathy or postpartum eclampsia. So here they will ask about postpartum hemorrhage. Then postpartum hemorrhage, they will ask the what do you mean by massive hemorrhage? So you have to know the definition of massive hemorrhage. and massive. Then they will ask about you the um, transfusion protocol and the definition of massive blood transfusion, and you have to know the trials, all the trials name, and they will ask about the definitive management on how will you manage the postpartum hemorrhage. First is uh, to oxytocin and blood and the pressure on the uterus to improve the tonicity of the uterus. Mohammed rightly said the balloon blockage, balloon component, or definitive treatment, either hysterectomy surgically or it is interventional radiology will do the embolization. So normally in a tertiary setup, embolizations prefer over the surgery, because surgery there is a chance of further blood loss, or this patient might have a DIC condition, so it can causes another complication. If you have the good radiologists, they can do the uterine artery embolization, which we do normally in our setup. Then they will ask about how will you diagnose DIC and manage the time you have to tell the ROTEM. So ROTEM or TEG, there are the rotem and take basically principally they are same, only in the take the piston is rotated, and in the rotem the container is rotated, but the technically there are little different, because in the rotem have check 5 parameters. One is your uh, extem, intem, heptem and fiftem. Normally, four is the main, and there are similarities. The in the take it is R time, or Rotem said it is CT. The K time it's CTF. The R time is the coagulation factor. Mainly, the factor deficiency causes prolonged R time or CT. And K time is the initiation of the clot to produce 2 mm strength on the your clot buildup. And this CTF also having the effect of coagulation factor plus fibrinogen and the platelet here. And then there is a alpha angle. The difference between alpha angle in ROTEM and TEG is 2 mm to 20 mm of the clot stem, or here only 2 mm, no 20 mm. Okay. So 2 mm is the alpha angle. That is the difference between TEG and your ROTEM, but they check the speed, how it reaches 2 mm to 20 mm in the tail, or in the 2 mm, how much the angle. So they will give you the abnormal, the normal value and the abnormal value. And this angle is represent the how fast. So it is the your platelet activities and the fibrinogen activity. Then your maximum amplitude, in the TEG it is called maximum amplitude MA, and in ROTEM it is called MCF. Then there is a time to reach the maximum amplitude, and here it is MCFT. The both are the same. It is again indicate your fibrinogen activities, fibrinogen level and the platelet. Then there is a lysis 30. Lysis 30 is the lysis index at 30 minutes, and lysis index 30 minutes for both are the same. It is a fibrinolytic activities or clot stabilization activities. If there is any abnormality, you have to give the tranexamic acid. And here the MA or MCA, if there is a abnormality, then you can do the FIB-10. FIB-10 will tell you whether it is a fibrinogen problem or absolutely thrombocytopenia is causing. So if the FIB-10 is normal, then it is a problem of the platelet. If FIB-10 is abnormal, then it can be both, or fibrinogen level is the problematic. And this all about your and extem and intem is extem is the external factor, it detect the external factor, and intem is detect the internal factor. So if the R is prolonged in intem, that and intem is normal, so intrinsic factor is okay, the extrinsic factor is problem, and it represent your APTT. And in extem, the factor 7, if extem is normal or abnormal, it is depending upon the external pathway, and it is represent your PT. Okay, that's all about the ROTEM and the TEG. So any question in this part?
Thank you, sir.
Okay.